There was on New York Times. I was telling somebody about this today. We've got chickens, and our local neighborhood doesn't. Our local community in Alabama doesn't have a local newspaper, and so we needed something for the chickens to poop on. So I ordered a subscription to New York Times, and so that was the only purpose for the subscription. But 2 or 3 weeks ago, the headline, before I was about to use this to catch poop, I noticed the headline was about pharmacy benefit managers, and I was shocked and surprised to see that publication talking about the corruption in that space. You didn't really talk about pharmacy benefit managers. I was wondering if you could educate us about that.
I can a little bit, but because we have been out of it for over 2 decades now, it has changed so much since then. But the corruption runs so high, and you can thank the Affordable Care Act for it. For instance, CVS Pharmacy owns their own pharmacy benefit manager. So the higher the price that is paid, the more money CVS makes in 2 different areas. So also when that pharmacy benefit manager goes to Premier Blue Cross or another third party to manage their prescription coverage, the higher the dollar amount is, the more money they make. It's crazy. The top 7 of the top, the 7 of the top 10 biggest companies in the United States now are healthcare companies, and that used to not be. You can thank the Affordable Care Act for that. And I think anytime there's a pharmacy benefit manager involved, it's going to increase prices. Obviously, there's another person involved. That's why Janet and I believe in directly billing the consumer. And I believe that any pharmacy that bills those pharmacy benefit managers, the pharmacists are accessories to the crime. I just say it like it is anymore. If you are in that realm, then you're an accessory to the crime. So on our podcast, Health Solutions with Shawn and Janet Needham, I interviewed a guy that knows the ins and outs of pharmacy benefit managers. And so if you look that up on our YouTube, you'll find that. And it's appalling. In any other industry, it would be illegal. I'm serious. We would not accept the things that go on, but we allow it in healthcare. It's unbelievable.
I'm going to piggyback off of that and unpack one aspect that we've made multiple references to, the insurance price being higher. And I realize there's kind of an unstated assumption here that is a bit of a head scratcher for a lot of people, because unless you're in this industry, you're operating on the assumption that, well, insurance wants the price to be low because that's how every other kind of insurance works. If you have an insurance company who collects premiums and then has to pay out claims, the lower the claims they pay out, the more they can, the higher profit they can turn. And that it's in that regard that insurance is unlike any other kind. The health insurance is like unlike any other kind of insurance, because one of the unintended consequences of the Affordable Care Act was something called the medical loss ratio. And that stipulates that for a fully insured product where they're taking in premiums, 85% of the premium dollars that they take in has to go towards medical care. And so you end up with a perverse incentive where the insurance company is only allowed to keep 15% of the pie, and that's capped. And so the only way that they can increase profits is by increasing the size of the pie. And so the way that'll usually go is they'll go to a health system, and it gets even crazier when you realize that they sometimes own the health system. But they'll go to the health system and they'll say, we're going to need, we had 60% off billed charges last year. We're going to need that to be 65% this year, or you're out of network. And then the health system will say, well, okay, we're just going to have to raise our prices. And so then the insurance carrier says, okay, we're good with that, because they're now collecting their 15% off of a higher number. And then even when they're on so that's for the fully insured products. On the self-funded companies where they're still acting as providing ASO, administrative services only, their selling point to the employers is, look how broad our network is and how deep our discounts are. So there too, if somebody comes in and says, hey, I'm just going to bill a fair price right off the bat, the insurance company has absolutely no incentive to work with that provider because they need the extravagant bill charges that they can then say, look at how much we've saved you, because that's how that's their other source of revenue stream. So you end up with a situation where every gatekeeper and decision maker actually wants the bills to be high. And then they make these charades of negotiating discounts and then, saying, oh, prices just keep going up, medical inflation, nothing we can do about it. But it's actually all very intentional.
Can I, Matt mentioned the monopoly game concept, and you kind of alluded to this with that structure. Somebody in the room mentioned that they were at a hospital that has the company Sound Physicians running the hospital medicine part of the hospital and also the emergency medicine part of the hospital. This was just kind of a exercise I did recently because I was just curious. That company, Sound Physicians, is owned by Optum, who also owns United Healthcare, which is one of the biggest insurance companies in the country. They also own several large hospital chains throughout the country. They also own one of the largest medical billing practices, Change Healthcare, which had a huge hack recently that Congress had to intervene to fix. Costs bazillions of dollars. So anyway, it's I had a pastor who used to say that it's like three wolves and a sheep arguing over what's for dinner. Like we know how that's going to go, and that's kind of the situation that we're in. So anyway, I was just going to mention.
They say you don't want to learn how hot dogs are made, right? We've learned a lot about hot dogs in the last just by being virtue of stepping out of it. But I mentioned just how cost-effective medicine can be. Even in the inflationary years of the last few, our costs of doing X-ray because we pay cash for it have not gone up, and our costs of doing meds of about 3 to 5% over the last 5 years, and labs about the same. I mean that's crazy when you step back, because everything you read is saying 10 to 15% every year, but it's just not so. It's actually the administrative burden and the cost of insurance that's driving it.
I'll speak to that too. And in our pharmacy, we have not raised our prices in 7 years. And we refused during this inflationary period to raise our prices. Now, one of the reasons we keep our prices low is we have low overhead, and our employees are only dealing with direct patients. We don't have all this other administrative costs. So we can control a lot of that. We can control our expenses like a lot of places cannot. And I think it's a testament to realize what a scam the rest of the system is. Now, Jan and I do have a kind of a different kind of philosophy in our pharmacy. Just to let you know, we are two pharmacists that don't believe in medications to treat most long-term disease. I know that sounds crazy, but we realize that, our sick care system is not working, and big pharma treating all these diseases is not making people better. So one of our goals is, when we can get out of that system, is that we can educate patients about their overall health. So, and that's been very, very rewarding. And you could not pay me enough, literally, to go back to the other system. I could not do it for any amount of money ever.
While we're waiting for cards, I'll let you review those. Matt, you mentioned, I think it was like 64% are self-funded, are part of self-funded plans. What is a self-funded plan? Could you explain what that is?
So there's kind of three main parts of the way you can be insured if you're an employer. There's the fully insured, which is what more traditional, what we think of as health insurance, which used to be sustainable. You used to be able to just ride that train and be fine. And but that's where you just pay a single premium, and then the insurance company takes on all the risk. If they do well, then if the costs are low, then they pocket that money. And if not, then they lose money. They're never going to lose long-term because they have good actuaries, and they'll raise the prices. What we've seen, the latest trend is that they raise the prices regardless, 9, 20, 30. I've seen one as high as 100%. It's become unsustainable. Then there's kind of three technical forms of self-funding, and we just won't get into those details, but self-funding is essentially where the employer is taking on some of those risks, and they're typically having what's called stop-loss insurance that would kick in, depending on the size of the company, maybe 50 grand for each person. If it's a larger company, 150 grand, what they call an individual spec deductible, and then an optional aggregate deductible, which would kick in, which almost never hits, less than, I don't know, 2 or 3% hit the total spend. So the company is taking on most of the risk, and then we're not seeing them manage that medical spend yet, which would be the smart thing to do, right? To try to keep costs down. But then if they did come out ahead, then that would be their money. Or if they get a lot of spec hits, then their stop loss goes up. And so that self-funding is the only way to really, I think, sustain long-term in what we're seeing in the trends in the industry. But you have to have a good medical strategy with it. Otherwise, you're rolling the dice on your spend. You don't want your spend. What we've seen in the past, what determines your spend is just whether someone got sick. That's not going to fly anymore, because especially if someone gets real sick, like cancer or heart surgery, we're seeing hundreds of thousands of dollars and sometimes millions, and then your plane crashes in 1 year.
Here's one for Dr. Story. Is it possible for DPC to charge a, quote, fair price versus a monthly fee? If not, why not? So I think the question is basically, why not fee for service?
I appreciate that question. We actually looked at doing that, and we ran into two different difficulties with just charging as you go. Because we actually did that during our first 6 months, and we had several patients that said, would you just charge me? So what we did is we went and basically took Medicare, which is the lowest paying billing rates, and asked that of patients who came to see us. They hated it because they felt like we were nickel and diming them. So if they paid for every visit, every phone call, because that's what actually insurance companies or most clinics do. Many people don't even realize it. For every form completed, they hated it, and they willingly came back and said, "Please sign me up for membership." And it was such a more sustainable model. The second is it really is part of the baked-in process for low administrative costs. So because we don't have to chase down billing because it's a monthly fee, we set it as low as we possibly can. We've only increased it twice in the 6 years, and that by $4 or $5 a month. And most of around the country are dramatically less than if you were to bill for the same services. We recognize that it's not a great fit for everybody, but we find that it's actually a pretty remarkable way of partnering families and individuals and businesses with doctors in a way that lets both avoid a lot of the red tape. Membership model also actually creates a whole separate structure that lets us avoid some of the networking challenges or entanglements. It basically creates an organization that lets us negotiate on behalf of people in a way that lets us be independent, which turns out to be really important in medicine right now.
Can I add to that? Yes. It would seem another answer to that, or another dynamic to that, is that in a fee-for-service model, you're incentivized to see them more. Whereas in a membership model, you're incentivized to keep them healthy. So there's no incentive for you to have the person come in a lot. You're not getting rewarded for that. You actually, in the way you're doing it, want them to be healthy. Anyway, that's just another.
I do think that that's true. We do have a cap of 12 visits per year. And you're welcome to see us above that. We asked for a little bit beyond that. It turns out that almost nobody wants to see a doctor 12 times a year. and we're all about that. Like, let's help you do that. But if you do have one of those years, man, you do want a doctor that you can see a lot of times.
Yeah. So one of the things I'll share is the gym analogy there too, right? Is like, if I had to go into the gym and every time I did a bench press rep, I had to pay more for that, right? And so in healthcare, we talk about the Pareto principle, which is 80% of your spend is driven by 20% of your population of your employees, right? That can even be drilled down further to 50% of your spend is 5% of your employees, right? And so in the membership model, while not everybody's going to go to the gym every single day, get their workout, right? And so we're paying for potentially a membership, but people who aren't using it as frequently, we're worried and concerned about the 80% spend of those 20% people. So we can get those 20% of those people into your office on a regular basis and really trying to tackle their chronic conditions on an upstream basis. Now you're really attacking the high-end claimants there.
On the employer side, you basically have paid for a benefit that is an open door. And in our circumstance, when you come, not only are you going to get care that day or next, you're going to get the very best price for labs and meds, and there's no incentive for us to jack it up. And we think that's a marvelous place to be able to be fully transparent on what we do.
I'd like to comment. I got one of the things
That's okay. For us DPC physicians, our patients to call and they have symptoms. We get to jump on it early.
Yeah.
And so that's why we got our hospital costs got to go down. Everything, if we're doing preventative medicine or anti-narcotics, it's no big deal. But we get to their depression results, we get like early.
Yeah. This is Dr. Haney was successful in Ellensburg, sold his practice out in Sandpoint, if you find your way up there.
I think one of the easiest ways to explain it is that, with a monthly fee, it's easy to budget. And I mean, when you look at it, Netflix and gyms and cable bills or whatever, they know that. They know people go, okay, well, you can afford $50 a month. That's what we're going to charge. And the cool thing about this is when you don't have a contract with an insurance company is you get to decide as a healthcare provider. And I'm sure I'm speaking for Dr. Story, but I'm sure some of those people that have more than 12 visits a year, you get to decide whether you charge them or not. And I'm guessing many times you say, yeah, this one's on us. And you have the ability to do that when you're not handcuffed by an insurance company. I don't know if you know, but I think Congress stopped it from happening. Of course, Congress causes these problems and then they ride it on their white horse and fix the problem. But there was a gag order on pharmacies for a while. Dr. Story talked about how much he can save people on medication. So if you went into a pharmacy and you showed him your insurance card, oh, well, your copay is going to be $50, but the cash price of that same prescription could have been 10. The pharmacist was a gag order by the insurance company to not tell them that. They literally could not tell them. I mean, in any other industry, that would be illegal.
Yeah, quick comment on that. It was, thank goodness, I believe it was the Consolidated Appropriations Act that finally made that illegal now. But yeah, until just very recently, that was the case where if they disclosed that they had insurance, they were not allowed to tell them that the cash price was cheaper. Just crazy. I want to make one comment on something Dr. Story said. He mentioned Medicare rates. And I think one, kind of from a macro economic perspective on this is that what Medicare pays physicians is wildly different than what Medicare pays hospitals. And it has to do with more than Medicare because most of the insurance carriers are following suit on a super percentage of Medicare. So what Medicare does kind of sets the precedent in a lot of ways. And so you take like a typical surgery case, the professional fees, what's actually going to the surgeon is typically less than 10% of the total bill. And so the way this works currently is the professional fees are treated as loss leaders. And so that number, what we expect to pay for primary care, is artificially low because the health systems are subsidizing those fees in order to recoup the referrals, which is where all the billing actually for the facility fees, which is where the billing happens. And so part of the dynamic of when someone says, "Oh, but that's more than I'm used to paying for," or that's a steep cost for primary care, it's because the Medicare has set an environment where we have gotten used to artificially low cost for primary care, when in reality, when it fills its proper place, it expands to be something much more than that 7-minute visit that gets you to the hospital. It actually is preventative. It forms the bedrock of either a health plan or a individually or corporately.
Brief comment on that. We're not cheap. We know that, but we're honest. We're honest for what it costs us to give the care and what we think our professional value is that we bring. If you are paying Medicare rates, if you're an independent medical clinic, and we know many family physicians that are just about to close their doors because they are losing money on every single patient they care for. It's unsustainable. It's great on the hospital side and terrible for the family doctor. And it's destroying American medicine. This is one way of just stepping out and being straightforward.
Matt, do you want to comment? You've argued in the health plans that you set up, you set DPC as kind of that bedrock. Did you have any additional comments on how that fits in financially?
Yeah, I didn't know this when I first started way back in 2016. That was our very first step of the 30 plus pieces I mentioned that became this well-oiled machine. We started with, we were big enough to go on site, really the same thing as near site in terms of functionality. But that became, we soon realized within a year or less that should be the medical director of our plan. So like the model that I described today briefly, but in detail in the book and so forth, and that I'm practicing with employers, the DPC is the heartbeat of the medical strategy. It cannot be done without it. And I would say then if you go further, it's a great start. The important point there is that the success though long term is really DPC plus DSC, direct specialty care, any specialty referrals. Because of the DPC, it could be the health plan's limitation, or it could just be a lack of providers around. But if they're referring straight back to the hospital, you're interrupting care in a good way. You're doing a lot of good things, but I don't know if the employer health plan survives without DPC plus DSC. So the health plan has to be transformed and redone. And then all the DSCs in the state need to grow. As you saw the slide, right? We have new imaging, new infusion, new surgery centers, on and on and on. We also want to encourage that. I always view it, right, buyer and seller, by the way, as like a rowboat, 2 oars. So the buyers are on the commercial side, the non-government side, 60 to 70% nationwide are the employers, 80% roughly, and then the employees, and then the sellers. In this case, the sellers of fair prices, independent physicians, hospitals too. They'll come around once they lose enough revenue. But if one of those oars is rowing, the boat's going in circles or not rowing. So as we grow this movement, we need DPC plus DSC to grow on this side. And then we need employers to get in the game on this side, and those need to kind of grow together, because if one of those is missing, this whole thing has trouble. We're essentially juxtaposing, building a new medical system alongside the current broken one, and then watching it kind of become this free market. Some would say, as a final comment here, some would say, why don't we wait for right? Someday, somebody, this very generic language, will fix this problem. We have to realize the healthcare industry as the status quo. Now, I want to put people into categories, but the status quo, hospitals, BUCA insurance, and status quo brokers, this is not a problem for them. So if you're waiting for them to fix it, you're going to be waiting a long time. They're doing really well. So we have this win, and then we have the employers are driving toward a cliff and not pumping the brakes or turning the wheel. We have a lose. Win-lose is never sustain. That's what's kind of interesting. You think they'd want to fix it because they're about to run over their customers. We want to find win-wins. We don't want them to lose. The buyers, we want win-wins. But just the notion that if you're waiting for this industry to fix it, they're not going to do it because they're getting very wealthy on it.
Medical spend hit $4.5 trillion a year last year. That's a fifth of our GDP. So there are, as Matt said, the BUCAs are profiting very heavily from this. And that leads me to this question. What are the BUCAs? BUCA is short for Blue Cross, United, Cigna, Aetna, the major consolidated insurance carriers. Correct. They loved the ACA. This question, what is typical design structure and cost for adding insurance benefit to a DPC? How do employers protect employees for catastrophic expenses, for example, cancer? A number of us, Matt, that's probably in your wheelhouse, but I'll just start this one off. I would not advocate someone. I'm a fan of pooling risk. When we are anti-insurance company. That's not anti-safety net. And there's a number of ways that you can do that responsibly. If you are, if you're a large company who's mandated to provide insurance for your employees, then the kind of plans that James and Matt here specialize in putting together are self-funded. You're basically just eliminating the perverse incentives and taking fiduciary responsibility for the management of that plan. If you're an individual or a small employer, that's where something like healthcare sharing ministries are a fantastic solution to pool that risk. So you're not actually, you're not being irresponsible. You're not going without protection. You're just eliminating the massively perverse incentives of the BUCA carriers.
Yeah, well said. There are a lot of employers, even fully insured employers, which is kind of the exception, but employers can just add on, even they keep their health plan the same, fully insured or self-insured will add DPC. They can even pay them out of their accounting department. It doesn't have to be through their third-party administrator. So we see a lot of that. No, that's a great first step. I wouldn't stop there, but they say primary care can be as much as 80 to 90% of our care and cover most everything we need. And of course, the question goes to what about the catastrophic, the serious stuff, because we need that too. And then, as David mentioned, there's different options. If you're 50 employees or above, and we have one that's 35, for instance, it can be done. It's just that one extreme case can blow up a small plan because they don't have the cushion of all the payers. But it could be a level funded. This is one of the types. Could be the self-funded with stop loss. And then the health share ministries, I think, are probably the future of those employers, in my opinion, of 50 or less. And so you stack, and in fact, they give you a discount for DPC. So you stack DPC, and then you stack that on top. And the only exception would be if you have a pre-existing condition or extreme cases, you might have to move them to a marketplace, which there's not a lot of great things about ACA. If there is one, at least remove the pre-existing conditions for the marketplace, where the employer can kick in and subsidize that. You're going to pay for it. You're going to pay dearly for it, but at least it'd be fair to give every employee some coverage.
One comment to add to that is, there's a lot of ideological aspects to this, philosophical, how should medicine be practiced and all that. But one really neat aspect is that it's extreme. The solutions are actually very pragmatic. At Veritas, for example, we're currently in a contract negotiation with a 10,000 employer company. And because they have employees all over the country, they use Blue Cross to administer their claims. And what we do with companies like that is something called a bolt-on, where they're self-funded. They still use Blue Cross to process all the claims because they have, they need to be able to tell their employees you're in network all over the country. But then what they do is because they have a BUCA plan, they get the pre-authorization codes when there's a major surgery. And so then they're in a position to reach out and say, hey, Bob, we saw a pre-authorization code come in for a total knee replacement. We just want to remind you could go to any in-network facility and that'll be subject to your deductible and your co-insurance and your max out of pocket. Or if you're willing to travel to one of our direct contracted partners, we're going to waive that cost for you completely, fly you there first class, put you up in a nice hotel, you and your spouse, and they're putting that choice into the employee's hand and saving them, thousands of dollars. And so for something major like a total joint, we're talking, the plan is looking at a $50,000-$60,000 expense versus a $20,000 expense. That delta in savings, they're able to pass on to the employee voluntarily, and so you get it's never coerced. It's entirely their choice, but they're basically lining up the incentives to say, if you're willing to work with us, we're going to reward you financially for that.
So I think the original question was the plan design piece of, health plans with DPC. And so there are some third-party administrators that are actually getting behind and seeing the value of direct primary care. And it's more of a level funded model where the premiums that an employer would pay are similar to a fully insured, where it's, if you're used to paying $500 a month for Blue Cross plan, maybe this plan is $400, and in that $400 is the direct primary care membership for an employer built into there, and then the rest of that money is going to pay for the high cost catastrophic coverage. But then there's also a bucket of money that is specifically there to pay for claims that are outside of the direct primary care. And in that situation, typically we'll run care coordination programs where it says, hey, if we can find high quality, low cost providers, we will waive all cost share for you, right? So in this model, we say, hey, 85% of the care can be done at the direct primary care piece, right? No cost when you go to direct primary care. That's built into the membership that you have through this model here. But in that situation that something has to go outside of there is a bucket of money out here. And if you work with our care coordinators, we'll waive cost share. So you don't have a deductible, you don't have an out-of-pocket maximum, you don't have any costs, right? And a lot of that's driven off of what's known as price disparity, that hospital A charges $100,000 for this. Hospital B charges, maybe they get a good deal. They're $60,000, but maybe the cash price of it's $25,000, right? So as an employer, you're looking at, at the end of the day, even fully insured, you are paying that premium. That premium that you are paying every single month is your money that the insurance company is spending on your behalf. It's kind of like taking your kids clothes shopping for back to school, right? Are you going to give them a blank card and go to Nordstrom's, or are you going to go to Kohl's, right? And that's really what insurance is it's a blank credit card that your employees have to go spend however much money at whatever store. And that's really where the transparency comes in with the care coordination, to say, hey, if you're going to follow and we can find the low cost provider, we're going to waive all cost share because we know price disparity. We can get the lowest cost and we're willing to waive that because we're going to save on the back end there. And so it's just a different model when you're able to waive that cost share and have a lower cost than just simply having that Blue Cross plan.
And I would like to, as a side note, since we mentioned health shares, and Matt even talked about it with smaller employers. Some of the health shares, I know we had this happen when my son broke his leg, and it was a $48,000 bill. Even though they weren't supposed to give me a discount, they did me a big favor and gave me a discount. And it was a 20% discount. So $48,000 was about $9,000. And I had a $5,000 deductible, and health shares doesn't really have deductible because it's not insurance. But anything I negotiated off a discount went towards my deductible. So I paid zero. And after we, as you can imagine, getting the bills from a hospital when you want a detailed bill and they ask you why you want a detailed bill. Well, because I'm paying it. That's why. Seriously. I mean, imagine if you did that at a hotel and what would you say if they said, well, no, we can't give you a detailed bill. Seriously? So it took me months to negotiate it, and it was a good process, and we went public with it, and we posted on our podcast, and the hospital marketing person basically challenged me and said that, this was defamation. I'm like, am I being honest? And she says, well, yeah. And I'm like, well, then you should come on our show and you should defend your position. She never did, by the way. And anyway, so after we decided on the bill, and I told the health sharing ministry that we're good to go, they had a check for $35,000 in my hand within 7 days. Never, ever would a health insurance company do that. Ever, ever.
We're not insurance. DPC is not insurance. And so we actually dissuade a number of people from joining us. And we tell them, please go cover your catastrophic first. Make sure that you're not going to end up in the deep end, because medical bills do that in our country. They put people in the deep end. But I will also tell you that 41 of our businesses, almost all of them are small. And we do have a couple of that are larger. But when we're talking about small businesses, we're the first foray into providing a medical benefit. And we're way more cost effective. What they often then offer to their employees is, first off, an opportunity to get real care that's usable and beneficial, and an entry point into an honest marketplace. But then also an opportunity to then make sure you got it covered, and allow the employee can then go into the marketplace and find that catastrophic coverage, knowing that they're really covered quite well for most of what they need a doctor for. And that's a really remarkable place to be able to help small businesses who are just trying to make sure their employees get some health care, not just coverage, that turns out to be in most cases very unusable.
I just got a text reminding me that they have to set up for another event after us, so we'd better wrap up. But thank you so much for all the speakers who joined us, and let's give them a big round of applause.